Very good evening to all. It gives me great pleasure to welcome you all to this evening's meeting. We have gathered here today to share the ideas, learn from one another, and work together towards our common goal. This meeting is arranged by Ahmednagar Academy of Pediatrics. Our Dr. Sagar Wagh sir has arranged all this. Before we begin, I would like to extend my gratitude to all our respected guests, Dr. Ramakant Patil sir, Dr. Amol Pawar sir, Secretary Maha-IP, Dr. Sanjay Deshmukh sir, our senior pediatrician, Dr. Tamboli sir. I also welcome Dr. Ravindra Sonane sir, Treasurer Maha-IP, then our seniors, Dr. Tade sir, then our today's speaker, Dr. Vinay Joshi sir, Dr. Sandeep Kadam sir, and Dr. Kuldeep Sukhdeve sir. And I also welcome Dr. Sadavarte sir. This evening, we aim to celebrate newborn screening month, which is always in September. So this is a coincidence. We are having this Neonatology CME on this month. And I'm confident that with everyone's active participation, this meeting will be meaningful and productive. So without further delay, let's begin with our today's agenda. I hand over mic to the Dr. Sagar Wagh sir, who is aspirant for National EB member, and sir is working for our IIP Ahmednagar since many days. He is very cooperative, and our scientific convener, we have completed almost 109 activity with his guidance, and sir is always there for many activities. Over to you, sir, Dr. Sagar Wagh sir.
Good evening, all. Am I audible?
Yes, Sagar, you are audible.
Yeah. Yes. Good evening, all. Thanks to my IP team for allowing Ahilyaanagar IIP to conduct the CME. I thank the President, Dr. Sanjay Pakmode sir, the Secretary, Dr. Amol Pawar sir, the Convener, Dr. Sanjay Deshmukh sir, for allowing the Ahmednagar Academy of Pediatrics to conduct this CME. I welcome the respected seniors of Ahilya Academy of Pediatrics, Dr. Suchit Tamboli sir, respected Dr. Nana Sahib Akolkar sir, Dr. Sham Tarde sir, who are present to the CME for the CME, and today's speaker, Dr. Joshi sir, Dr. Sandeep Kadam sir, and Dr. Kuldeep Sukhdeve sir. So a very good evening, everyone. A warm welcome to all the respected teachers, seniors, colleagues, fellow pediatricians, and postgraduate students who have joined us today. On behalf of Maha-IP and Ahilyaanagar IIP, it gives me a pleasure to welcome you all to this neonatal CME. Neonatology is one of the most dynamic and challenging areas of pediatric practice. As a clinician, we often encounter situations in NICU where timely decisions can make a crucial difference. The topic chosen for today's CME reflects some of these real-world challenges that we face in the neonatal care. We have three relevant and practical topics lined up today this evening. First, we'll discuss approach to the congenital heart disease in newborn, an area where early recognition and stabilization are absolutely vital. Next, we'll address neonatal sepsis not responding to antibiotics, a scenario that tests both in clinical judgment and our understanding of antimicrobial resistance. And finally, we'll deal with the antifungal use in NICU, a topic that's gaining increasing importance with the rising burden of fungal infections in the preterm and critically ill neonates. We are fortunate today to have with us three eminent, highly respected faculty members who will share their expertise and practical insight of these topics. So today, I welcome first Dr. Vinay Joshi sir. Madam. Dr. Vinay Joshi sir is a neonatologist. He is a pediatric cardiac intensivist. He is working in Wadia Children's Hospital. He is trained in clinical research, ECMO, CRRT, functional echo. The special achievements are Cochrane Review, national and international publications, chapter in books protocols. Special interests are in cardiorespiratory interactions, functional echo, and bedside USG simulation-based learning. He is a past EB member of Pediatric Intensive Care Chapter India. He is the president of Pediatric Intensive Care Chapter Mumbai, president IIP Mumbai 2002-2021, and a member of Maharashtra Pediatric COVID Task Force. Welcome, sir. for the CME. Our next speaker is Dr. Sandeep Kadam sir, who is a consultant neonatologist, KEM Hospital, Pune, and he's a professor of neonatology at BJ Government Medical College, Pune. And our third speaker, none other than my teacher who has taught me, Dr. Kuldeep Sukhdeve, who is a professor of pediatrics, DMMC Nagpur, and a senior consultant of Kingsway Hospital, Nagpur. I welcome you, sir, today for today's session. So we'll start with the topic. Okay. So today's first topic, the congenital heart disease in newborn, often present with a subtle or non-specific signs, which we sometimes just persistent desaturation, shock, and failure to improve despite of standard management. Early recognition and timely referral can make a life-saving difference. Many of us working in the peripheral or even tertiary setups face diagnostic and stabilization challenges in these babies. Understanding the clinical approach to the congenital heart disease in the newborn is therefore essential for every pediatrician and neonatologist. To guide us through this vital topic, we are privileged to have with us highly respected expert in this field. I welcome Dr. Vinay Joshi, sir. Over to you, sir.
Thank you very much. Good evening, all. And at the outset, let me thank Maha IIP for giving me this opportunity, and you have chosen a topic which is very, very important and very close to my heart as well. Can I share my screen? Okay. Yeah, so let us
Yes,
start.
sir.
Am I audible, visible?
Yes, sir.
Slides are visible? Yeah.
And PPT is visible.
Okay, perfect. Thank you. So let us start with the question. How many of you will be comfortable to see this kind of baby wherever, whether at the time of delivery, in the postnatal ward, or when you're sitting in the OPD and the baby comes who is absolutely blue, like this? I don't think anybody will be comfortable, and I'm sure because not only it gives us a challenge how to manage this child, but even to diagnose, to understand its pathophysiology and the mode of treatment. So all these are very, very challenging, especially when you are sitting in the OPD setup or whether you are in the postnatal ward. So as already mentioned, the diagnosing the CHD or congenital heart defect early and the timely referral is extremely important. So next 15 to 20 minutes, what I'm going to talk about is, what is the burden of congenital heart defect in India, or this part of the world, how the baby is present, and how we are going to recognize these babies at the earliest, diagnose, and then subsequently they will be managed. And in the end, we'll just review the entire approach and end up with some slide. So looking at the burden, the total congenital heart defects at birth, these are the estimated, numbers a few years ago, and I don't think they have changed much. And this is the prevalence in India, where 130 to 270,000 babies are born every year with congenital heart defect. And of that, critical congenital heart defect, the ones who require intervention in the infancy or in the neonatal period, there are around 80,000 babies. And the mortality reported is almost, it contributes to 3 to 20% of your infant mortality. So you can imagine it is one of the most important etiology or the contributing factor to infant mortality rate in India and this part of the world. And how many of these critical CHD, we talked about the 80,000 numbers, they require intervention in the infancy and the neonatal period. Of that, only 1.6% they end up receiving the treatment. So we can imagine the burden of the problem and associated morbidity and mortality with that. So if these babies are not recognized in time and they don't reach a tertiary care center, quaternary care center where the cardiac facilities are available, and if they're not treated in time, there is a huge amount of morbidity and mortality. So where is the problem? The problem at various levels. So one, we have a huge burden of CADs which require immediate intervention in the infancy, that is around, say, 80,000. The detection, the diagnosis, there is a main hurdle. Why there is a problem in diagnosis of this CHD at the earliest? That may be because of the sheer number itself, the infrastructure availability, the expertise available at the periphery, and at the same time, maybe the lack of awareness among us pediatricians as well. We have to have a high index of suspicion, and we should be looking for it. So maybe that is the reason, we fail to diagnose these babies in time. And if we don't diagnose them in time, then of course the timely referral is not going to happen. And even if you diagnose many of the times, the transfer becomes an issue, because again, the logistics are involved in that. And when I say transfer, it's just not the transfer, the scoop and run. You pick up the baby and run to the place. Rather, the baby has to be stabilized. So baby has to be stabilized first and then transferred. So that kind of structured transfer facilities are again is a major issue. Of course, the cost involved in that, all those factors. And once this timely referral happens or the baby reaches the treatment center, see, by the time there is a lot of delay, the baby from the diagnosis to the reaching the treatment center or the tertiary center, then there's already the morbidity has set in. And if there is high incidence of infection in these babies, they are already hemodynamically extremely fragile, unstable, and you have to stabilize them first. And once the stabilization happens, they go for the surgery. So I can tell you many times, we have lost the babies at the signal. Baby has come all the way from, periphery, traveled 250, 300 kilometers, reaches the signal of the hospital, and the baby, arrests. And this is not unusual. It has happened many, many times. Sometimes if they reach the emergency and we start the CPR. So I think the entire problem is with the numbers, with the diagnosis, and the way we transfer these babies, and of course, the cost involved. So all these factors lead to the increased morbidity and mortality. Now, this is a UK study. This is not from our side. Most of the 50%, more than 50% of babies with undiagnosed congenital heart disease, which comes to light in infancy, are missed by routine neonatal examination. So you can imagine, how many babies are missing, and more than 1/3 by the 6 weeks examination. So again, the diagnosis remains a main problem in all this. Why CHD is missed at birth? Various reasons. One is the limited access to healthcare, resulting in little supervision by the pediatricians. As the access to the healthcare is the problem. At the same time, the diagnosing, the available of expertise, available of pediatricians many times, and the limited exposure of most pediatricians to pediatric cardiology. Or therefore, even if it is not the exposure, at least an awareness also extremely important. So one must be looking for this, because if you diagnose them, and you can transfer them at the earliest. And why cyanotic congenital heart disease or the congenital heart disease is often missed at birth? Because the cyanosis, particularly peripheral cyanosis, is common in newborns, and sometimes we miss out on that. Cyanosis that worsens on crying must be investigated further. So that is very, very important. So if there is a cyanosis and if it worsens on crying, then the baby should be investigated thoroughly. And the newborns with cyanotic congenital heart disease often look completely well initially until the shunt, the intracardiac shunt, either ASD or especially the patent ductus arteriosus, begins to close, and that's where the duct-dependent pulmonary circulation, it collapses, and then the baby becomes cyanosed. So initially, these babies look absolutely normal. So if we don't diagnose these babies earlier in neonatal period or infancy, that lead to high rate of mortality. Delayed diagnosis leads to ischemic brain injury, hypoxic brain injury, multi-organ failure, and of course then associated high. Even if they reach and they get operated, there is higher post-operative morbidity associated with that. So what is the role of pediatrician in diagnosing the congenital heart defects? The early detection of CHD with a view to minimize mortality and morbidity. So if you diagnose early, then definitely we can bring down the morbidity and mortality associated with that. So how should a pediatrician at the periphery approach to congenital heart disease? And basically now I am not happy with the term congenital heart disease. Rather, it should be a congenital heart defect most of the times, because Once many of these defects, when you correct them at the right time, then the outcomes are absolutely fine and they live almost a normal life. So coming to the etiology, so how we should look at these babies or how to approach these babies. One, even though it's a sporadic event, it is not uncommon. So one needs to look at, and it has got a genetic origin. So if there is a family history, if there is a history of sibling affected with the CHD, then the risk, of course, it increases. So we need to look at that. Take a good family history. Look for history of CHD in the family or in the near relatives, in the parents. If the mother is exposed to exogenous teratogens, then that history is very, very important. The teratogens could be anything. Could be drugs, could be toxins, could be infections like torch infections, or even the maternal medical conditions like diabetes mellitus. I think the history should be asked, carefully. If the child has any chromosomal abnormalities, the syndromic babies, if you have, obviously the child is syndromic, the child has high risk of having CHD. And as you can see in this chart, the most of the obvious chromosomal defects or the syndromes, they are associated with significant cardiac defect, from the septal defects or even to the chronotruncal anomalies or even the arch abnormalities. The common teratogens what we come across is mainly the torch group of infections, the exposure to alcohol or the drugs like phenytoin or lithium, and of course the maternal condition, as I mentioned, diabetes. So basically, if there's a history of diabetes or and not well controlled, these are the babies which can have significant cardiac defect. And sometimes the structurally heart may be normal, but they can have cardiomyopathy as well, like the septal hypertrophy and RVOT obstruction. Many of the CHDs we can detect in the antenatal period, or if you are and with the presentation of the signs and symptoms, we can diagnose them at the neonatal or in the postnatal period. So coming to the antenatal diagnosis, the antenatal diagnosis is the ideal in the setting is the ideal way it should happen. Why these babies, even though they have significant heart defect, their perinatal survival is not affected as long as blood is delivered from caval veins to aorta, so bypassing the non-functioning chamber. So even the condition like hypoplastic left heart syndrome or the tricuspid atresia, pulmonary atresia, they are life-threatening. When the baby is born, babies can present immediately after birth. But in the antenatal period, they survive without any problem. They grow well. It is because they bypass that affected non-functioning chamber through the patent ductus arteriosus. So most of the anomalies, if you look carefully, those defects can be picked up at 20 weeks of gestation. And whatever the little bit data we have, the detection rate could be anywhere between 3 to 60%. So still there can be missed out, especially the arch anomalies. They are missed. They can be missed in the antenatal diagnosis, whether you do the anomaly scan or even sometimes when you do the fetal echo as well. So the advantage of early detection or antenatal detection, basically, then these babies can be delivered in the tertiary care center where the cardiac the facilities are available and they're equipped to deal with stabilization and subsequently intervention, whether it is catheter intervention or the proper surgery. So coming to fetal echo, what are the indications? So if you find abnormal findings on the routine scan, routine sonography, yes, yeah. So definitely you should, the mother should go for fetal echo. If there's a family history of significant heart defect or heart disease, like either the sibling or the parent, high risk pregnancy, like as I already mentioned, the mother who has the uncontrolled diabetes or gestational diabetes, then the mother has collagen vascular disorder like SLE, and maybe our mother has been exposed to teratogens, any of these, either the drugs or the infections. after the antenatal period and birth, now once the baby is born, some of the heart defects they can present in the first few days, the first week of life. So if you look at this 0 to 7 days, you can see the host of defects which can present. So most of the serious defects are presented here, like transposition of dead arteries, all the atrasias, tricuspid, pulmonary atrasia, TAPVC, especially intracardiac. Then all your outflow lesions like hypoplastic left heart syndrome, aortic stenosis, coarctation, interrupted aortic arch, all this can present in the first week of life. And if tetralogy, even tetralogy can present in the first week, if there is a RV, severe RVOT obstruction, then they can present even the first 7 days. So these are most of the critical CHDs they present in the first 7 days. So one has to be on lookout for these, and for that the thorough examination is very, very important, and the screening before we discharge these babies. And then other important period comes, that is 3 months after 2 weeks, or after a month or so, and the ones which present after that are the coarctation. I think the coarctation and all your septal defects, the tetralogies which have got minimal RVOT, double outed right ventricle syndrome, etc., they can present. One of the conditions which we should be careful, and it is not a structural heart defect, but it can present, these babies can present with cardiogenic shock, that is anomalous left coronary artery, and they usually present after 3 to 6 months or the second half of the first year, I think. So one has to again be careful with this. So neonatal presentation, they can present with cyanosis with or without respiratory distress. We'll see the conditions later. They can present in cardiogenic shock, the following closure of the PDA. This is especially for the duct-dependent systemic circulation. They can present with pulmonary congestion secondary to left ventricular overload. They can present with congestive cardiac failure because of the high output state, that is the septal defects, and sometimes they can just have asymptomatic murmur. So I think, and subsequently they will present the later part. So this is just a representative case. Day 7, term neonate came to us with severe cyanosis and very minimal respiratory distress. The child was discharged on day 2 of normal delivery and became suddenly ill, and baby was rushed to the hospital. So this baby has severe cyanosis. So what could be the differential diagnosis? Any baby who comes to us with cyanosis or dusky, in a state of shock, we think in terms of either respiratory or cardiac. That is the most obvious thing, but there are other differential diagnoses as well, like pulmonary hypertension, very rarely methemoglobinia, and of course sepsis in our setting should be the one of the differential diagnoses. So if the child presents with cyanosis, then we should look whether it's a cardiac origin or pulmonary origin. These are the 4 different clinical signs one should look at. One is look at the onset. Usually the pulmonary or the respiratory origin, respiratory distress present in the first few hours of life, not later. But the cardiac ones, usually they present later. The cyanosis is more obvious in cardiac cases as compared to the respiratory distress of pulmonary origin. Here you will see mainly central or differential cyanosis. In the pulmonary, you will see only central. There won't be differential cyanosis. And of course, then comes the complicated history. If you go into the history, you'll find that most of the babies born have there is no significant antenatal history, no significant birth history. While in the pulmonary, there will be some risk factors which are playing around. So these are the 5 ways, the 5 important aspects one should look at when it comes to diagnosis of CHD. One is the clinical examination, keeping in mind the high index of suspicion. You do the chest X-ray, ECG plays very limited role in the diagnosis of CHD. Measurement of oxygen saturation, I think this is one I think I will emphasize, and I will see why it is important. And secondly, you do the hyperoxia hyperventilation test if you deal with cyanosis. The common clinical presentation, you look at babies can have tachycardia, they may have even rhythm abnormality sometimes, murmur present, absent, But usually, if there is a diastolic murmur, that can be significant. If it is a grade 3, grade 4, so the audible murmur, again, that you have to be very careful, and definitely will follow the thorough clinical examination. If the baby is presenting in shock, then you will have weak pulses. If there is coarctation or interrupted aortic arch, you will see the weak femoral pulses, cold extremities, delayed perfusion or impaired perfusion, delayed capillary fill time, and child may present in shock with hypotension. There will be some respiratory symptoms depending upon what kind of lesion you are, especially if you are dealing with PVC or a high outflow stage, then probably the child will present with tachypnea, retractions, and decreased air entry and crepitations, etc. We'll talk about that again later. This is one important examination I think one should do when the baby presents to you in the OPD. So I call this the fifth vital sign, that is pulse oximetry. So I think this is very useful instrument, and any child who comes to you with um, cyanosis or respiratory distress, one should look at the saturations in the upper limb, that is basically the right arm, and the lower limb, and see the saturation difference. So any saturation difference of more than 5%, sometimes when they take it as less than more than 3%, then you should be worried. If saturations are less than 90% in the upper limb and lower limb, that is a concern. And if it is less than 85% in 100% oxygen, again, you have to be very, very careful. So I think the saturation in the upper limb and lower limb one should check. And if there's a differential saturation and with a difference of more than 3 to 5%, again, that should raise the alarm. And if the saturation is persistently less than 90%, these babies should be screened. This screening can be done after 24 hours of birth. So especially if the baby is in the postnatal ward before discharge, all the babies should undergo screening for heart defect. And one of the important way to do it is, look at the upper limb, lower limb saturations. You can examine the baby for murmur, and you leave the forelimb blood pressure. I think without that, the baby shouldn't leave the hospital. And if the baby is coming to you for the first time, you're seeing the baby first time after birth, I think all these things should be done can be done in your even outpatient. So this is a wonderful paper, the Swedish paper, which was published way back in 2007, so almost 15, 20 years ago. And what they found that if you use the upper limb, lower limb saturation, that is use of saturation monitor or the screening of these babies before they go home, the specificity of diagnosing congenital heart defect is almost 99.5, 90, almost 100% for that matter. So you won't miss out on that. Okay, the dose sensitivity is less, the specificity is very high. So I think my advice to everyone, the request to everyone is, before you send the babies home from the postnatal ward, or if you're seeing the baby for the first time after birth, I think one should do the upper limb, lower limb saturation. The pulse oximetry is very, very important. So what are the clinical scenarios with which this CHD can present? The baby with cyanosis, the baby can present with hypotension, poor perfusion, and metabolic acidosis. The baby can have features of congestive cardiac failure, and sometimes the baby can be asymptomatic, but there'll be a murmur. So I think these are all the presentations which can happen, and they can come to you. And so one should suspect these babies to have CHD. So newborn with cyanosis, with pointers towards CHD as the absence of grunting and severe intercostal retraction. So they have comfortable tachypnea, but they're cyanosed. Okay. Differential cyanosis or reverse differential cyanosis. Again, that is the difference in the upper limb and lower limb saturations. Abnormal physical examination associated with abnormal chest X-ray and abnormal hyperoxia, hyperventilation test. So these are the indicators which point towards the congenital heart defect. If the child presents with hypoperfusion, hypotension, poor perfusion, so these are the signs they present with: cool extremities, weak pulses, motile, lethargic. There will be there are some degree of metabolic acidosis, and in that case, you should consider that there could be a duct-dependent systemic circulation, and the duct is closed, and that's why the child is presenting. most of the babies, when they present to us, I think the first differential diagnosis, what we put is the sepsis. And I think, correct me if I'm wrong, I think that is the first differential diagnosis. But that's true. But having said that, along with sepsis, you need to consider the other possibility, the child, if they has these symptoms and there is abnormal cardiac examination, then we should be looking at something, sinister congenital heart defect. If the child has presented to you with failure to gain weight, or there is a congestive cardiac failure, the significant respiratory distress. So usually, if there are large, these are the defects where there is a large left to right shunts, and the baby is present with typical presentation of respiratory distress. They have suck, rest, suck cycle. I think the mother will tell you that when you ask her about the feeding history. And these are the babies or the children who present, later part of infancy. They have repeated respiratory tract infections, and definitely they have a poor growth. I think if these settings, if this is the clinical setting, one should think in terms of large left to right shunts. And how the child with tough-like physiology will present, I think usually they are the ones, they can have cyanotic spells, which we studied while during your residency. So I think if these are the different ways of where the child can present with cyanosis, the child can have pulmonary, there could be pulmonary the causes, could be PPHN, the cardiac defects, and other the conditions. Now, coming briefly on hyperoxia test and hyperventilation test. Well, what you do here, basically, you give 100% oxygen via hood in a child who is suspect of CHD. Do it for 10 minutes and take ABG. It's not the saturation. You have to do the ABG and you look at the PO2. If the PO2 is less than 70, it's most likely congenital heart defect. And if the PO2s are more than 200, you're almost ruled out congenital heart defect. Now then comes the gray area where the PO2s are between 150 to 200. Here you have to have some more information. You may need to further test and monitor the child, and maybe the 2D echo will be the answer. And how we do hyperventilation? Hyperventilate the child at 100 breaths per minute with oxygen and repeat an ABG. As the PCO2 normalizes, the PO2 and pH improves, and this will tell you that this is PPHN. But if the things don't change even after that, again, the pointers towards will be something wrong with this. So there is a shunt. So neonate with unexplained pulmonary hypertension with cyanosis always exclude CCHD, that is complex critical congenital heart defect. And one of these is the obstructed TPVC. Many times we have received the babies with the diagnosis of PPHN. And when we looked at the heart carefully, when we did the echo, there was obstructed TAPVC. So I think there's always a problem, the differentiating TAPVC from PPHN and PPHN from TAPVC. So we have seen this many times. So I think that here the echo by the expert, the cardiologist, is very, very important. So rule out obstructed TAPVC. What masks the CHD at the time of birth or in the early infancy? I think that they are basically the intracardiac shunt. So one shunt is at the ductal level, that is patent ductus arteriosus, and second at the atrial level, that is atrial septal defect. And they can mask. And what the duct does, if there is a duct-dependent pulmonary circulation, as we can see here, when the duct closes, your pulmonary circulation is compromised, and as the pulmonary circulation is compromised, the baby presents with cyanosis. The typical example, as in this case, you can see the pulmonary atresia. So there is atresia here, so the blood cannot flow in the pulmonary circulation. It is dependent on the duct, patent ductus here, and as the duct closes, the pulmonary circulation is compromised. If there is a systemic circulation which is dependent on the patent ductus arteriosus, as in this case, coarctation of aorta, or even in the interpreted aortic arch, what will happen? This is the coact here. What you can see, there is a duct which is maintaining the systemic circulation, and once it closes, the systemic circulation is compromised, and then the child will present with shock, poor peripheral pulses, poor perfusion. So coming to RB, if you remember, the child presented to us with cyanosis. The SATs were 58% in the right arm, 55% in the left foot. This was the blood gas, which when we did, the CO2s were normal almost, but if you look at the PO2, the child had significant hypoxemia there, and the base axis, the building metabolic acidosis, pH was 7.18. We did the hyperoxia test. No, hardly any change. PO2 they went up to 48, and the base axis remained the same. The pH worsened rather. So this is what we were looking at. This child has cyanosis, and so probably here what we are dealing with, something there is compromise in the duct-dependent pulmonary circulation, as the child presented on day 7. So these are the differential diagnoses we should be looking at: the duct-dependent pulmonary blood flow. One of them is tetralogy fellow with pulmonary atresia, critical pulmonary stenosis, tricuspid atresia, pulmonary atresia with intact ventricular septum, etc. Coming to the chest X-ray, I think I'll just run through a few slides where we look at the X-ray. X-ray is very important, but in the immediate neonatal period or infancy, the X-ray changes which we were taught during our residency, that Egon end appearance or snowman's appearance. These are the classical pictures which we normally don't see there. But what I would like to emphasize here, you should look at the pulmonary vascularity. You can look at the heart size. You can look at the situs. You can look at other like cardiothoracic ratio. And of course, don't forget to look at the lung parenchyma and the diaphragm and the bony cage. So this is what we were taught. Snowman appearance of PVC, that Epstein's, you can see subsequently here, you can see the Egon string appearance, that is TGA. Then this is the 3-day-old newborn with deep cyanosis, subsequently found to be DTJ with intact ventricular septum. This is a very significant or critical CHD which requires immediate intervention because there is no mixing happening, and they can present very sick to you in the first week of life or even earlier than that. The cyanotic baby with X-ray, if there's a cardiomegaly, think of Epstein's as a hyperemic lung fields, as I was mentioning. The TGA could be there, or even TAPVC. I'll talk about something about TAPVC later. If you're coming across oligemic lung fields, tricuspid atresia, critical PS, pulmonary atresia, etc. As I said, ECG doesn't, I think ECG can be read by the cardiologist. These are the few significant findings you can see on ECG. You should get the ECG and look at the abnormalities, what I mentioned here. But at the same time, you should look at the rhythm, etc. when you do the ECG. Now, this is our child. As you can see, there is right ventricular prominence and oligemic lung fields. So you can see that relatively you have to look at the normal lung fields and the oligemic lung fields will easily make out. So definitely there is a problem with the lung blood flow here. So how will you, these are the management principles of critical congenital heart disease. One is the stabilization. I think stabilization is extremely important. When I say stabilization, it includes airway, breathing, circulation. You have to take care of everything. Acidosis, you have to correct and look at the lactate, and the lactate plays a very important role, and it tells us, the metabolic state of the child. Normalization of the temperature, maintain normothermia throughout. Maintenance of glucose, very important. These babies can be hypoglycemic as well, and they can complicate the things. IV fluids, sometimes they require even the boluses to correct the hypovolemia because they had inadequate intake. So that is very important. And then, of course, if you're suspecting CHD and you are thinking in terms of either duct-dependent pulmonary or systemic circulation, you should start prostaglandins. You shouldn't delay it. If the child is sick, starting prostaglandins will not harm. So this child had pulmonary atresia, as you can see here. So this RV is the pulmonary artery, and there is atresia. So what the child was diagnosed, child was stabilized, and subsequently, once the stabilization happened, then we started prostaglandin infusion. the child settled, and then day 2, day 3, once all the parameters are near normalized, we had a couple of options. This child can go for PDA stenting or BT shunt. It depends, the skill of the cardiologist. So nowadays, more and more people go for PDA stenting, but if the anatomy is not favorable, then we go for BT shunt as well. This baby had a BP shunt day on day 12 after the stabilization of all other organ systems. Now, this one slide on the prostaglandin administration is very, very important. It helps in maintaining the patency of ductus arteriosus. We start at anywhere from 0.01 to 0.1 mic per kilo per minute. But my advice will be, if you are suspecting CHD, then you start at 0.05, that is 50 nanograms per kilo per minute. And once the duct opens and once the baby stabilizes, then you try to wean it down to minimum possible dose so that you can maintain the patency of the duct. Why? Because high dose of the prostaglandin infusion can cause apneas and then other complications like fever, the GI complications like vomiting, feed intolerance, etc. So if the child develops apnea on prostaglandin infusion, you should be prepared for intubation. And this is especially very, very important during the transport. If you're transporting a baby on prostaglandin infusion of higher dose, or even if it's a prolonged journey, these babies can have apneas. So it is better, sometimes it is better to intubate and then send the babies to the tertiary care center. So again, I will reiterate, in a suspected cyanotic CHD baby, initiating prostaglandin will not harm the baby, even if the final diagnosis may be PPHN. I think I repeat, and even if it is TAPVC, it won't do harm, because sometimes it will even open the ductus venosus and it will reduce the load on the right side of the heart. So starting prostaglandin, you're not doing any mistake. So don't worry, you can start prostaglandin infusion. Now, certain interventions can be done immediately. They are the palliative interventions just to stabilize the child. Like if the duct is closed in TGA, as we saw in that X-ray with intact ventricular septum, then here we do the create an ASD, atrial septal defect, that is balloon atrial septostomy we do. That is the surgery, and so that we allow the mixing of right and left side of the blood and improve the oxygenation. So let's go through the management plan. Early detection to prevent long-term morbidity and mortality. If you are diagnosed antenatally, if you could diagnose, then the delivery room stabilization and transfer to level 3 NICUs has to be done. And if you can transfer these mothers in utero, that is wonderful. Small team examining pre-discharge structural referral pathway can lead to 90% detection of CHDs, and this is what I was talking about. So proper screening of the baby before they go home for cyanosis, murmur, femoral pulses, upper limb, lower limb saturations, and forelimb blood pressure is extremely important. Postnatal detection, if any baby is less, has, again, either you have to screen for saturation and use the proper technology so that you don't miss out on that. Stabilization include all the components, thermoregulation, metabolic parameters like glucose, calcium, correct hypovolemia, airway management is very, very important. This is very important. Don't try to achieve the saturations to normal or even 90%. 70 to 75 saturation is more than enough for the babies. Okay, so if you have to give oxygen, it has to be very, very minimum. If there is lung pathology associated with that, I will use CPAP, but 21% oxygen. So I think avoid unnecessary excessive administration of oxygen, because what you're going to do is you're going to close the duct, which is maintaining either pulmonary or systemic circulation. Start prostaglandin, see if there is acidosis and baby is desaturating. Of course, the echo is the gold standard when it comes to diagnosis. As you can see, that absent tricuspid valve, and in this case, again, this child will require either PDA stent or the BT shunt, something like that. Here you are seeing is the parallel circulation, the aorta and pulmonary artery, they are running parallel. So this is a TGA. Look for the additional test if there is a signs of dysmorphism, get the karyotyping done. Always look for the other anomalies like the head abnormalities or the kidney sonography. Transport, very, very important. Early referral is optimal. Before you transport, I think you have to convey a few things, what you are suspecting. The referral doctor they will tell you how to manage their child, how to stabilize that child, and during the transport throughout, this baby should be monitored thoroughly, prevent hypothermia, prevent hypoglycemia, etc. And
Sir, we should.
avoid झालं अजून एक 2 मिनिटं.
Yes, sir.
Avoid hyperoxia. Period of greatest hazard, it is a pre-operative state, before and after admission. Once the baby goes to the theater, I think they fix the things. The problem is with the pre-operative state. If you give the child in a good condition, they will give us the child back in good condition. So there are a few interventions. I'm not going to go into details of that. And the surgeries, depend upon the type of defect. If it is TGA, we go for arterial switch, TAPVC repair. If there is a coarctation, then definitely you will go for the coarct repair or the arch repair. This is a simple algorithm. I think this is the last slide from my side. So if the baby presents with duct-dependent pulmonary circulation, your prostaglandin remains the treatment of choice, and they can have either BT shunt or PD stenting. If it is TGA, here you will require either balloonatal septostomy plus or with or without PGE1, and they undergo arterial switch. TAPVC, we don't start normally prostaglandin because it doesn't help, and the surgery is the only choice. When it comes to TAPVC, one thing I would like to tell, if the baby is preterm, and after giving 2 doses of surfactant, if there is no improvement in the chest X-ray and the baby continues to have respiratory distress, one should think of TAPVC. TAPVC can happen even in the preterm babies. So remember that. I think we need to always keep that in mind. And if it's duct-dependent systemic circulation like hypoplastic left heart or coarct, then of course the PGA1 will remain the treatment of choice. So when it comes to outcome, depends on many other. This is a team of doctors. It's a teamwork. So we have obstetricians. They should be actively interested in that. They should be referring to the. If antenatal diagnosed, they should refer the patients to the proper center. The neonatologists, cardiologists, surgeons, anesthetists, intensive care, and of course, a lot of paramedic stuff. Making precise diagnosis is important. Decision to operate or intervene, surgery or transcatheter intervention, and subsequently either successful cure or palliation. But all these factors depend only on one thing, that is suspecting heart disease and diagnosing at the earliest possible and transferring to a correct place or the tertiary cardiac center. Thank you. Yeah, I'm done.
Thank you. Thank you so much, sir. It was really nice lecture and very enlightening for congenital heart diseases. The really different perspectives and enlightening many management issues. Thank you so much, sir. Any questions from audience? Pallavi madam.
Yes, ma'am.
The second
Sagar
speaker.
sir. Yeah. Sagar sir, are you there?
Sir दिसत नाहीये, sir.
There.
Yeah. Yes, sir.
I welcome Dr. Sanjay Deshmukh, sir, convener. I request him to say a few words for the CME.
Yes, good evening. Firstly, special wishes to the all esteemed MAHAPI members for MAHAPI. The session is going on fantastically. I don't want to be in between the another speakers. I will thanks IIP Ailanagar. The purpose of MAHAPI is to involve smaller branches on the academic platform. And we're thankful to IIP Ailanagar, Dr. Sagar, Dr. Suchit Tambuli sir, Dr. Sachin, So they are all a dynamic team. They have done fantastic midterm CME with their great efforts. And this is due to possible efforts of our MAHAPI president, Dr. Sanjay Pakmode, and Secretary Dr. Amol Bau. So that's the way we can involve more and more branches on the MAHAPI platform. So thanks to Ailanagar, my best wishes, and thanks for the happy learning.
Thank you, Dr. Sanjay Deshmukh, sir. I welcome our EB member, Dr. Sachin Wadne also, who is our from Ailanagar to the session. Now we move ahead for the second session, neonatal sepsis not responding to antibiotics. Despite starting broad spectrum antibiotics, there are times when neonates continue to deteriorate or show no clinical improvement. At this stage, timely reassessment, identifying possible resistant organisms, considering non-infectious causes, and appropriate escalation of the therapy are essential to improve outcomes. To shed light on the systemic approach of and management strategies in such a difficult situations, we have with us Dr. Sandeep Kadam sir, a wealth of experience in neonatal critical care, and will guide us through practical steps, differential diagnosis, and evidence-based management when sepsis does not respond to antibiotics. Over to you, sir.
Yeah. Good evening, everyone. Am I audible and are the slides seen?
Yes, sir. Yes, sir.
So at the outset, I would like to thank the MAHA IIP Ahilanagar branch, Dr. Sagar, and respected teachers, seniors, and dear friends. Next 20 minutes, we are going to discuss about neonatal infections not responding to antibiotics. Well, when I started my training in pediatrics, my guru and my mentor, Professor Dr. Anand Pandit, well, he told me when you diagnose rare things in medicine, you are rarely correct. And this was my first lesson, which I learned that you should not, as a young postgraduate students, we are all the time looking to make rare diagnoses, fancy diagnoses, and he used to correct us. Don't think of rare things because they are rare. And when I started my training in DM, my teacher, Dr. Jayashree Monkar, told me one statement that in our country, when you make a diagnosis of neonatal infections or neonatal sepsis, you are going to be correct 8 or 9 out of 10 times. So, coming back to our topic of neonatal sepsis, it is the commonest diagnosis. If you ask anyone, it is one of the most common diagnoses that we give our babies who are discharged from the NICU. Probable sepsis, clinical sepsis, culture negative sepsis, culture positive sepsis, so on and so forth. We all know antibiotics are used, misused, abused. Whenever we see a baby who is sick, we grade up the antibiotics, and it's universal. I'm sure all of us have done it, and probably all of us would continue to do it even tomorrow morning. So what we are going to discuss today in the next 20 minutes is case-based discussion as to how we can see whenever we are faced up with a problem of neonatal sepsis which is not responding to antibiotics, what do we do? The first case, I'm going to take 5 cases. This is a term baby weighing 3 kilos. This baby was transferred to us in view of respiratory distress and fever on day 5 of life. The baby was febrile, off-colored, lethargic, and the baby looked pale. There was tachycardia and tachypnea. Capillary filling time was 4 seconds. The mean arterial pressure was 33, which was quite low for this baby. And our impression was this was a typical late onset sepsis shock, probably a gram-negative infection like Klebsiella or E. coli. So when we evaluated the baby, hemoglobin was 12, the total counts were low. Absolute neutrophil count was 1250, which was quite significantly less, and there was thrombocytopenia. CRP was 134, CSF done was normal, and the blood culture grieved Klebsiella. So as per the sensitivity, we had started the baby on meropenem and amikacin, and we thought that the baby would definitely do well and improve. So baby was initiated on antibiotics, however the fever persisted. There was no clinical improvement. The baby looked off-colored, and what do I do? Well, most of us probably today would have thought, let us grade up the antibiotics maybe to the next antibiotic, which is colistin, and then tigecycline, and what next? So probably if you realize in the last 20 years, there are rarely very few antibiotics which have been invented, and we keep on using the same antibiotics time and again and again. So in this case, what happened was that the mother and the nurse felt that the baby was crying while changing the diaper. and there was tender hip abduction on the right side. The ultrasound done showed a septic arthritis of the right hip joint. We involved the orthopedic surgeon. He immediately intervened, did a arthrotomy, gave a wash to the joint. Antibiotics were continued for 4 weeks. Fever disappeared and the baby clinically improved. So what do we learn from this baby? All babies with neonatal infections who are not responding to antibiotics, we need to do a proper clinical assessment, and by which I mean a head-to-toe examination. Please listen to the mother. And if she says that the baby is unwell, or if she says that there is something not right about the baby, or she might give us a clue that there was a movement which was tender, or there is a swelling which was not noticed by anyone but the mother noticed, we need to look for a localizing signs. So infections which are not improving with antibiotics, look for any suppuration. And in this case, it was a septic arthritis which was not, which would have never responded to just antibiotics. It would need a surgery. Similarly, if you see a baby with late onset infections, you may have meningitis, you may have a retroperitoneal abscess, you may have an abscess in the brain, and we or of endocarditis in the heart. So basically, we have to look at a suppurative infections, or abscesses, or a localizing lesion which would never respond to antibiotics alone. Second case. This is a term baby, female child born by LSCS 2.8 kilos, cried immediately after birth. This baby had respiratory distress after birth. In view of distress, the baby was transferred to the NICU. Presumptively, there was some maternal fever and query urinary tract infection in the mother. So we thought whether it could be a congenital pneumonia, transient tachypnea, or sometimes early onset infections with persistent pulmonary hypertension of newborn. Baby was started on antibiotics, baby received oxygen, but on day 4, this baby had abdominal distension, was off-colored. Obviously, we thought this is some sepsis which has progressed. Most often than not, we would think of a gram-negative infection, that probably we would also think of a hospital-acquired infections that comes to our mind. On day 5, this baby had fever, weak pulses, prolonged capillary filling time, and we thought of a shock which was probably related to sepsis and a septic shock. Most often than not, gram-negative infections often present with severe circulatory collapse and shock. CRP was 132. Here in this case, the sodium was low and the potassium was high. And obviously this gave us a clue that this could be an adrenal insufficiency. So we looked whether there's any adrenal hemorrhage or congenital adrenal hyperplasia. But more often in this case, what we thought was probably there was hypoglycemia, hypotension, hyponatremia, hyperkalemia. And this was a case of adrenal insufficiency, probably secondary to infections, but also once in a while you would see perinatal asphyxia, which can cause adrenal insufficiency, and therefore it can present with shock. So whenever you see a shock with hypoglycemia, we need to look for adrenals and do a serum cortisol level, and these babies would improve with a small dose of hydrocortisone. Coming to the third case, a term baby outborn referred to us for fever on day 12. Obviously, we thought of infections because it was a commonest problem that would come, and the blood culture gave Klebsiella. There was thrombocytopenia. There was leukopenia. This baby also had a big liver and a spleen. A sick looking child. We obviously started on meropenem and colistin, looking at a outborn coming from a tertiary NICU, maybe a hospital acquired infection, and these babies are often quite so sick with so much of leukopenia, thrombocytopenia. We gave antibiotics for 7 days, but the baby did not respond. There was persistent thrombocytopenia, persistent neutropenia. So what next? How can we grade up the antibiotics? Shall we start tigecycline, or shall we give some other antibiotics? What are the various possibilities? Should we look for any other differential diagnosis, and what are the way forward? So what here in this case, we obviously had a low platelet, a low WBC count, a low neutrophil count, and the CRP was very high, and so was ferritin. Echo was normal. So whenever you see a baby with persistent fever, splenomegaly, hepatomegaly, bicytopenia, and there could be possibility of hypofibrinogenemia or high triglyceride levels with increase in the ferritin, we need to start looking for hemophagocytosis, which is often a complication of neonatal infections, but once in a while you could also see a primary HLH or a hemophagocytic lymphohistiocytosis. It is a rare diagnosis. Please remember, this is not a common diagnosis, but once in a while if you see a baby with unexplained persistently high fever, splenohepatomegaly, pancytopenia, or at least 2 cell lines which are depleted, think of HLH. Commonest is secondary HLH, which is secondary to sepsis. It may be secondary to prolonged parental nutrition or sometimes rarely neonatal malignancies, and primary HLH was rare. In this case, we found that this was probably a primary familial hemophagocytic lymphohistiocytosis, which is an autosomal recessive condition, and this was a PRF1 gene that we could find in this baby. So obviously the prognosis in primary HLH is not so good. Outcomes are guarded. They may not improve to steroids or IVIG, and they may even not improve the anti-cancer drugs. So this condition probably would give us a clue that just grading up the antibiotics will not help, because here it was a case of a familial hemophagocytic lymphohistiocytosis. The next case here is a 29-weeker 800 grams preterm baby. Obviously, this baby was treated for RDS, received surfactant, was ventilated. Then baby was extubated on day 9, received CPAP for 10 days. This baby continued to have feed intolerance, and since it was a fetal growth restricted baby, we kept on having difficulty in feeding these babies. Recurrent in X-rays, sepsis workup was negative. What we found was there was mild jaundice and the platelet counts were slightly low. There was persistent thrombocytopenia of 40-45,000. Baby, as usual, received multiple antibiotics. We gave trial of antifungal. There was no response. The diagnosis here was infection, but what? It was a culture negative infection. CSF was normal, then there was something which we could never grow anything in the blood cultures. So this was a preterm SGA, feed intolerance. Baby looked well but unwell. Had low platelets. Urine culture was normal, CSF was normal. So we need to think beyond infections. Beyond infections, what I mean is beyond bacterial infections. And we sent a urine for CMV PCR and we found that the CMV copies were more than 1 lakh. And this was a case of CMV infection where we started on valganciclovir. And this baby also was screened for ultrasound head for any calcifications. We would do a hearing screen in the form of BERA or AABR. So whenever you see a baby with preterm fetal growth restriction, you need to start thinking of Torches clap group of infections where it could be toxoplasma, rubella, cytomegalovirus, herpes, syphilis, parvovirus. But what are the clues? Look for any occult markers. Look for a baby who is fetal growth restricted, IUGR, small placenta, low platelets, hepatomegaly, splenomegaly, pneumonia, encephalitis. Here we need to have a very high index of suspicion, and these are some of the infections which can present like infections and they will never respond to antibiotics. So this is something which we would think in such a case. Coming to my last case, if you see a baby with, this was a 28-weeker 800 gram born to a mother with PIH, a primary mother, LSCS was done for abnormal Dopplers. This baby was troubling us for feeding. There was persistent feed intolerance. Baby was given TPN through central line, received 14 days of IV antibiotics for late onset infection. There was persistent thrombocytopenia. Baby had big liver, big spleen. Even on day 34, this baby was persistent oxygen dependent and had low platelets. In view of persistent thrombocytopenia, hepatosplenomegaly and oxygen requirement, sepsis screen was sent, CRP was normal, urea create was slightly high, and this baby had a hyperechoic lesion in the right kidney which was suggestive of a fungal ball, and the urine screening showed a budding yeast, candida. So fungal infections are not uncommon in NICUs. It is something which we have to worry. We need to have a high index of suspicion, and these babies would do well with the antifungal administration in the form of amphotericin or fluconazole depending on the sensitivity. So what is it that this baby taught us? Any baby who has received multiple antibiotics, long line, TPN, steroids, prolonged ventilation, these are 5 conditions which predisposes a baby for invasive fungal disease. And this is something which is worrying because they can cause fungal balls even in the heart, kidneys or brain. And fungal endophthalmitis is something which can even worsen, cause visual impairment. So how do we reduce infections in the NICU? Skin to skin contact, cord cleaning with chlorhexidine, human milk, and that's something which is most important. Installation of mother's own milk, minimal invasion, bundles in the form of WAP bundle, CLAPSI bundle, and feeding bundle. And some neonatologists would use probiotics. So basically, to summarize, we need to have a good history. Unusual signs or symptoms should raise a possibility of infections. Clinical sepsis, we would start antibiotics after sending a blood culture. So we need to have a culture of sending a blood culture. Stop antibiotics as early as possible. I think today we should not talk of sepsis, but we should talk of asepsis, and that should be the culture of neonatal ICUs. here on. We should prevent infections rather than treat infections. So coming back to my last slide of my presentation. So whenever we see a baby who is admitted in the NICU with a diagnosis of neonatal sepsis and not responding to antibiotics, what are things that we should see? First, grading up the antibiotics every second day, third day, one after another. I mean, whether it's ciprofloxacin, meropenem, piperacillin, colistin, tigecycline, I think we should review our diagnosis. Is the diagnosis correct? Number two, am I giving the correct antibiotic? Is the choice of my antibiotic proper? Whether it's a broad spectrum, which we should not use, one should use a narrow spectrum antibiotic. We should prefer a bactericidal drug over a bacteriostatic drug. Look at the MIC levels of the antibiotics and then choose the right antibiotics. Is my dose correct? Have my baby with sepsis, has it developed a complication, whether it's septic arthritis or abscesses or meningitis or ventriculitis? Is the baby having any other possibility of diagnosis like HLH, which is secondary to infections? Fungal sepsis, Torches clap, and last but not the least, this could be a baby with immunological defects. And most often than not, if your baby is not improving and you've started seeing multiple infections, think of a primary immune disorder. It could still be a combined immunodeficiency or SCID, or sometimes it could be a neutrophil phagocytic defects that we have looked at. So these are some of the possibilities that the babies may not respond to antibiotics, and we need to have a high index of suspicion. So before I end, if you see a baby with neonatal sepsis not responding to antibiotics, we need to think. We need to review our diagnosis, and most important than not, we should do a proper clinical assessment in the form of a good history, clinical examination, and objectively assess, is my diagnosis correct, or do I need to look at something beyond sepsis? And that is how I would look at baby who is not responding to antibiotics. Thank you so much.
Thank you, Sandeep sir, for such a beautiful presentation. Any questions from the audience?
I think everybody is hypoglycemic.
Sir.
So there is a question in the chat box.
I-
Just 1 second.
I think somebody has asked, Dr. Sandeep, do you use probiotics?
Do you use probiotics in the both? Dr. Ramakant Patil sir asked, do you use probiotics in both institutes?
So, well, we used to use probiotics in KEM, and we found that it did help in reducing the need for antibiotics, and our risk of rates of NEC and infections dropped. But what has happened now is we've started using mother's own milk, and we have milk bank. So since we have got milk bank, we get donor human milk. It has reduced the need for use of probiotics. I think natural probiotic from mother's own milk is probably the best way to go forward. Sir, we don't, I must acknowledge here that Dr. R.D. Patil is my guru. Today I have become a pediatrician and a neonatologist only because he told me to take up pediatrics. How many percent of babies we use biofire? Sir, we don't use biofire. One, it is very expensive. And we do have backtech culture. So that's how probably it helps in having a good culture sensitivity. And we need to use at least 1 ml of blood in the blood culture bottle. Deepak, we use probiotic which had bifidobacterium and one of those lactobacillus as combination.
Any questions more?
Hello.
Yes, sir.
Sandeep, sorry. One more question here. Like you are using antibiograms or like that, particularly for choice of antibiotics.
Yes, sir. We review our policy of antibiotics every 6 monthly, but we do have an antibiogram, and our microbiologist shares that data every 6 monthly to show what is the sensitivity pattern. And today, if you ask me, sir, we are seeing a lot of multi-drug resistant bacteria, and there's very little that we have got in our armamentarium to use which drug for which bug. That is a problem. Pan drug resistance has emerged, and I'm shocked to see that some of the urine cultures that we see E. coli, they are resistant to everything, and we have very little. The community probably is colonized with MDR organisms. That is what the real scenario is.
So whenever you are sending set of blood culture, both the bottles you are sending for bacterial or one for fungal and bacterial?
We send bacterial only when we suspect fungal. We send a separate fungal culture, sir.
So you are sending 2 bottles at the outset.
No, only one. Most of the time it is bacterial that we send.
Okay. Have you given any student study for this? Whether sending 2 bottles have increased your yield or sending 4 bottles have increased your yield in bacterial when you are thinking. So sending how many times again sending a single culture, a set of 2 bottles or set of 4 cultures or 4 bottles.
Actually, sir, in neonates it is not feasible because it might cause more anemia. But if you look at some of the data from other older children, probably 2 bottles or 2 different sites, or sending a blood culture when the baby has fever probably increases the yield of identification. But in newborns, sir, we don't have that luxury and liberty to send so much of blood for blood cultures. We send one.
Only 1 ml.
1 ml.
Any other questions? Thank you, Sandeep sir, for such a nice presentation.
Thank you so much for giving us this opportunity this evening to be with all of you. And I'm sure we wish you all the very best for your upcoming elections.
Thank you, sir. Thank you, sir. Now we move ahead to our third and last lecture, that is antifungal drugs in NICU. Fungal infections in neonates, especially preterm and critically ill babies, continue to be a significant cause of morbidity and mortality. Early recognition, appropriate choice of antifungal agents, correct dosing, and understanding drug safety are the crucial for improving outcomes in these vulnerable patients. To guide us through this topic, we have with us Dr. Kuldeep Sukhdeve, who is a professor of pediatrics DMMC Nagpur and a senior consultant Kingsway Hospital Nagpur. Over to you, sir.
Thank you very much, Sagar. Am I audible to all of you?
Yeah, sir. Audible, but
Okay.
the patch still is coming, sir.
Okay. I guess uh, let me see what I can do. It's already 10:20, and the first thing I would want to do is justice to all those who are listening, and thank you all of you because of whom I'm here. And I'll start with the fifth case Dr. Kadam had presented. So that was that fungal infection. And let me take another 10-15 minutes where we can say something more about it. And this fungal infection is something which we were not talking when I was a student then. But because now that there are increasing survival of the very low birth weight and extremely low birth weight, and there are more surgeries, procedures, indwelling lines, now we possibly have more and more of fungal infection. But the saying goes that systemic candidiasis is an iatrogenic disease of modern neonatal intensive care. Let us start with that first case. So here is that case which tells us why we are now indeed having more and more fungal infections and struggling with it. So this is the first case. A typical NICU admission, a 1300 grammer. After the first hour of stabilization, everything looks okay. Possibly the patient is now into respiratory distress syndrome. Is put on bubble CPAP, surfactant is being arranged. The X-ray shows some kind of a reticular pattern, a surfactant is being given. So that means something is being done with the baby. So there is some intervention for IV line, surfactant, so on and so forth. A day later, we see that the child is still tachypneic, heart rate is more, CRT is more than 2 seconds, saturation is slowly dipping now, even an FiO2 of 50%. And some interventions in the form of in the form of investigations. And after retrieval of a blood culture, antibiotics started, and an iron ore probe started. After a couple of days, we still find the child has mildly improved. The antibiotics were continued. Oxygen was reduced. Nasogastric feeding continued. Now, this is a 1300 grammer, and he is in some hospital in Maharashtra. By day 16, the parents probably got lost all their money and they transferred to a public hospital or a hospital where it costs less money. So by day 16, he's on 20 ml 2 hourly of IG feeding, antibiotics were stopped. It seems to be quite okay and was passing motion. Another 10 days go by. Now, this is a very typical story of fungal infection. Slowly, intolerance to feeding, lethargy, reduced output, and then again, send investigation, send a blood culture, start an antibiotics, is put on vancomycin and amikacin in that hospital. By day 24, 25, hemoglobin is there, platelet count is down, urea is up, creatinine is very, very up. 1.1 is a very large creatinine for a preterm. Blood cultures, blood sample blood culture, the culture is awaited, and intervention, the treatments are being continued. There's no improvement in the child's clinical condition. Apneas have started coming up. The antibiotics, prepped up, deripenem, vancomycin, so on and so forth. Ultrasound brain was done, which seems to be fine. With that single bone, like I said, Dr. Kandam's last case, some fungal bones were seen in the pelvis of the kidney, and then the amphotericin started. So my first antifungal here, introducing my first antifungal would be an amphotericin B. So the feminist amphotericin B one must start in neonatal age group would be what is known as A, B, D, C, and the dose is 1.4. Unlike adults where it seems to be fairly toxic, it's less toxic in neonates. A very small dose has to be given. And while we are seeing the use of amphotericin, now some of these situations leads on to candidal infection. Using lot of third generation for cephalosporin for no reason could actually lead to emergence of candida sepsis. Okay, and the last stage, if you have liposomal amphotericin B being used, they tend to have in those children, they tend to have worse outcomes if you have a urinary tract infection being involved. So, the preferred treatment and lessons which understand this, many times blood cultures are negative, especially when they are very late onset sepsis. Keep a fungal sepsis and a urinary tract obstruction in your clinical diagnosis, or at least check for that. And fluconazole seems to be a much better antifungal than amphotericin B because it gets concentrated in the urinary tract infection much better. As far as cultures are concerned, in many institutions, it would be even less than 28% of them coming positive. So we have to be very, very smart to figure out what is happening. And if your patient is on that cheap 250 rupees amphotericin B, what is known as ABDC, and once you have a diagnosis of candidal infection, kindly do not shift to lipid formulation. So don't panic that this 250 rupees ABDC is not going to work. So let us buy 5,000 rupees highly expensive lipid-based formulation. Okay, so that was it. So if there is any one side which is more important in my discussion would be this. If you have a patient where you get a candida, whether it's a candida or any other any fungal infection, whether it's a yeast or a mold, this is the one which is going to help you figure out what is that you wish to use. Okay. If you, this slides have been transferred to Maharashtra IIP, so you can just pick it up from here as to what is the one which I need to start. Okay. So everybody knows about amphotericin B. The confusion is there are three types of amphotericin B now available in India. So which is the one which we should use? So I've talked about the simplest one, which costs just 250 rupees for 50 grams, 50 milligrams is the one which would work wonders in neonates. Okay. And the toxicity is very less, not much in neonates. And the reason of toxicity, in case you have, is possibly related to infusion. A lot of amphotericin B being transferred in 5 or 10 minutes. And this is the one which is the commonest. Uh, Amphotericin B, 1 milligram per kg, hardly now costs 250 rupees. The ABLC is another one which now I have started using in many of my patients. This costs you around 1,000 to 2,000 rupees. This is a lipid complex, but not a good one if in case your patient has a urinary tract infection because of a fungi. And these are the most expensive one. You can, even though they are lesser complication, the dose, a very high dose can be transfused from the first day, but a fairly expensive one. So which is the one? So even though there is no consensus, I would personally say the cheapest 250 rupees ABDC or an amphotericin B deoxycholate still scores better than the expensive amphotericins. Now that is the take-home message about amphotericin. So if you are indeed using amphotericin, we should know which one to use and why we are using it. Now, the second case, probably in 2 or 3 minutes, this is a case very typical of large neonatal ICUs, where you have 15, 20 babies there, because you would have many children or many neonates, maybe 4, 5, 6 of them on antifungals already diagnosed with a fungal infection. So a very typical case, less than 1,000 grams. So what should be your strategy? Would you want to use an antifungal? So the consensus, what I have gathered, is in case you have a very large NICU, number one, and fair number of children there on antifungals, we should start an antifungal prophylaxis, even though this discussion can end up with a lot of people having a lot of different thoughts. But in case we have an NICU where there is a fair fungal burden, a larger ICUs, starting fluconazole from first 6 weeks of life seems to reduce fungal colonization, even though I understand that final mortality cannot probably be reduced just by starting an antifungal. There could be many more reasons for a neonate to actually have a fair mortality. In case we wish to start, then it is nothing other than fluconazole, and which has to be started 3 milligram per kg twice or thrice a week. So that's about it. So 3 milligram per kg per dose, and you can give twice weekly. Some may want to give twice weekly as well, and you can start for first 1.5 months. So that is how it is. Okay. But how do we actually reduce the amount of fungal infection? So these are the ones Dr. Kadan had also talked about. You cannot just prep on starting moving up on antibiotics. Be very careful how much you are using, and cannot use a lot of cephalosporin. Be very specific when you are using it. Okay. Limit your steroid in case you're using for any reason. And like Dr. Kadam then said, EBM, enteral feeding, early enteral feeding probably would reduce many complications, not related with chest infections, but many other issues as well. Okay, so this is what he was talking about the fair neonatal gut microbiome, because we have started using very initially human milk feeding. So the Cochrane question was, should you use? Because now you may have NICUs which are small NICUs or very large NICUs. So be very specific when you're starting. If it is just a small 7-8 bedded NICU, probably a prophylaxis of fluconazole may not be needed. But in case large and at least 4 or 5 babies on antifungals with a culture positive, so that probably fluconazole helps. And that reminds me, there is a question some minutes back, whether you're sending one bottle or two bottles for the cultures. Now the backpacks which are available presently and the technology you have, you just have to send one bottle, they take care of everything. So that is about fluconazole. Now there is some confusion about what should be the initial dose of fluconazole. So textbooks are now saying that you can load with 25 milligram per kg and not 12 milligram per kg. You can load with 25 milligram per kg and start giving 12 milligram per kg per day if you know what organism it is, because some of these organisms can be only partially sensitive to the antifungals we are using. So what are the limitations? The limitations are many. Otherwise, fluconazole would have been the choice of an antifungal, because much better than amphotericin B. But the problem is sometimes you may not know exactly the subspecies of Candida, and there could be an absolute 100% resistance. Say, for example, in Candida cruzi and claberta. Okay, in that case, much better to start caspofungin or amphotericin B. Okay, there are risk factors and the various presentation, we all know how it actually happens, and all of us are aware that why it happens. But ending up my talk here with take-home messages that expect fungal infection as we are increasing technology and we are treating decreasing gestation babies. Expect fungal infection as the time is passing by, and as we did with antibiotics, now doing with antifungals, using exceeding amount of antifungals, and if child is not improving, so 1 antibiotic, 2 antibiotic, 3 antibiotic, then the first antifungal and occasionally the second antifungal, expect many of these fungi developing resistance. So be careful about it. The third take home is, even now, which is widely available, amply available, is a conventional amphotericin B, also known as ABDC, would be a much better idea. Okay, and many NICUs will have to use or may have to use fluconazole as a prophylactic agent in their ELBW babies. So there are these two small case scenarios. One about a small baby staying in the NICU for a very long time and getting sick. And second is with the fear that your small baby should not become sick, what you should do. So these are two different scenarios, and that is about it. And the forum is now open. I can take up questions.
Thank you, sir. My question to you and also Sandeep, sir, that you have told that use of aminoglycoside instead of cephalosporin for the empiric therapy when meningitis and antimicrobial resistance is not suspected. So only aminoglycoside is useful, and which aminoglycoside?
This probably stems from the fact that there's a rampant use of antibiotic. And like Dr. Kadam also said, that you have not one diagnosis of sepsis. You have got probable sepsis, and you have a likely sepsis. You have got culture negative sepsis, culture positive sepsis. So then for the epiphyt, when you're starting, be very careful cephalosporins. Like in my unit, we are absolutely not using cephalosporins at all, because our microbiology department talks about almost 100% resistant to cephalosporins. So be careful about it. And which aminoglycoside, I'll dare not say about it, because it would just start getting used. So if you wish to use 2 antibiotics for probable sepsis, till your reports come in, till your culture negativity shows up at the end of 72 hours, you want to stop antibiotics, probably adding a amikacin would be fairer than adding a cephalosporin. I'm not saying that amikacin or an aminoglycoside helps. Dr. Kadam, please.
Yeah, I think we have learned from what we have learned basically is that if we use cephalosporin, it results in production of ESBL producing gram-negative infections. So that is why microbiologists have told that stop using cephalosporin in the NICU, number one. And number two, what works good for you may not work good for me. So every NICU or every geographical location, we need to have our own data, have our own antibiotic policy depending on the antibiogram and the MIC levels. So I think what will work in Nagar may not work in Pune, and what works in Pune may not work in Nagpur.
Very true, sir.
Perfect.
In Nagar also, the NICUs in Nagar, they are using only aminoglycosides. We have centers in Nagar which the babies preterms are they are discharged only on aminoglycoside. So
I think less and less antibiotics is better and better for our babies. That is probably the carry-home message.
yes, sir. So a very nice lecture topic by Dr. Kuldeep Sukhdev, sir. Dr.
Thank you,
Sandeep, sir.
Sagar. Sagar,
And
here in this Sagar, in this platform, may I wish you all the best for your future and for your elections.
thank you, sir. Thank you so much, sir. Thank you, everybody, for taking all the efforts for the today's session. Thanks from the bottom of my heartful. Thank you for everyone, Dr. Sandeep sir, Dr. Kuldeep sir, Dr. Vinay Joshi sir, for taking out time from their busy schedules. I know how much busy you are and how you work throughout the day. And for this session, you have been here, sitting here. Thank you so much.
Thank you, Sagar.
Thank you, Sandeep sir. Thank you, Kuldeep sir.
Thank you,
everyone.
Dr. Sandeep,
I think
Dr.
so.
Vinay.
I will take but 2 minutes, Dr. Ujjwala, for the vote of thanks.
Best wishes, Sagar, for your
Thank you, sir. Thank you, sir. Thank you, Vinay, sir.
yes, election.
Excellent presentation, sir.
Thank you very much, and thanks. Best wishes.
As we come to the conclusion of insightful and enriching seminar, it is my honor to deliver the vote of thanks on behalf of organizing committee, Ahmednagar Academy of Pediatrics as a secretary. The first and foremost, I extend our deepest gratitude to today's guest of honors, Dr. Pakmode Sir, MahaIP President, Dr. Amol Pawar Sir, Secretary MahaIP, Dr. Sanjay Deshmukh Sir, Scientific Convener, and our Scientific Convener, Dr. Sagar Wagh Sir. And also I thank to Dr. Ravindra Sonone Sir, Dr. Ramakant Patil Sir for joining this session. I also extend my vote of thanks to today's speaker and enlightening us with very good knowledge, Dr. Vinay Joshi Sir, Dr. Sandeep Kadam Sir, Dr. Kuldeep Sukhdeve Sir. Your presentation and discussions have been incredibly informative and engaging and offering us new perspectives and ideas. To our dedicated organizing committee, Dr. Sagar Wagh Sir, along with our seniors, Dr. Tamboli Sir, Dr. Akulkar Sir, Dr. Tarde Sir, Dr. Karpe Sir, Dr. Agrawal Sir, Dr. Bangar Sir, and all members of Ahmednagar Academy of Pediatrics. Thank you for your tireless efforts and meticulous planning. Your hard work, the scene has ensured the smooth execution for this seminar. We also extend our appreciation to our today's partner, and your generous support has been instrumental in making this event possible and successful. A special thanks to our participants and attendees for your active engagement and enthusiasm. Your presence and contribution enriched the discussion and made this event collaborative success. To the technical support team, Dr. Pallavi ma'am, we are really thankful for your smooth execution of this program. In conclusion, thank you once again for your invaluable contribution and participation. You have made this seminar a memorable and impactful experience. Happy Navratri to all. Thank you for being here. Thank you so much. Good night.
Thank you.